Hello everyone, my name is Dr. SALIVARY. This lecture will deal with the evaluation management of salivary gland tumors. So in this lecture, we'll be dealing with the following topics. We will discuss major and minor salivary glands in terms of their anatomy, pathology of benign as well as malignant tumors, their evaluation and treatment. And finally, we will have a small summary. So salivary glands are divided into major and minor salivary glands. Major salivary glands consist of the paired, parotid, submandibular, and sublingual glands. There are a number of minor salivary glands spread across the oral cavity and the oropharynx. Salivary gland tumors are very rare. They only consist of 3 to 4% of head and neck neoplasms. Coming to the salivary gland tumor incidence, the most common region to see tumors are in the parotid gland, followed by the submandibular, sublingual, and minor glands, especially in the palate. The ratio of benign to malignant tumors is 4:1 overall and in the parotid gland, but in the submandibular and sublingual glands, one can see a 50-50% incidence of benign and malignant tumors. While in minor salivary glands, the malignant tumors are much more common with a ratio of 1:3 of benign to malignant tumors. Coming to the major salivary glands, first we'll discuss anatomy. The parotid is the largest of the three major glands. The parotid lies within the investing layer of the deep cervical fascia. It is divided into superficial and deep lobes by the facial nerve. As you can see in this image here, this is the facial nerve that is running through this parotid gland. The lobe that is above, superficial to the facial nerve, is the superficial lobe, and whatever the gland tissue that is deep to this is the deep lobe of the parotid gland. The retromandibular vein and the external carotid that can be seen here pass through the gland. This duct of the parotid gland is called the Stenson's duct. The gland is supplied with sensory and secretomotor fibers by the auriculotemporal nerve. And there are numerous intraparotid nodes and paraparotid nodes which provide the lymphatic drainage of the gland. In this image, we can see the facial nerve dividing the gland into a superficial and deep lobe, and the external mandibular and vein and external carotid retromandibular vein and external carotid artery running through the gland. Now the facial nerve, the anatomy of the facial nerve and its relation to the parotid gland is very important because identification of the facial nerve is a main step in parotid surgery. The facial nerve emerges from the stylomastoid foramen. It exits the skull through the stylomastoid foramen and enters the parotid approximately 1 centimeters after exiting the skull. So the facial nerve can be identified in its course before entering the parotid gland. It divides the body of the gland, as we discussed before, into a superficial and deep lobe, and it has variable branching. Here you can see the various types of facial nerve branching. Coming to the submandibular gland, the submandibular gland lies in the submandibular fossa. Here you can see this is the mandible and this is the submandibular gland. It hooks around the mylohyoid muscle. This is the hyoid bone, and this is the mylohyoid muscle here. And the submandibular gland is hooking around the mylohyoid muscle. The gland of the duct of the submandibular gland, or the Wharton's duct, arises from the deep part. This is the deep part and this is the superficial part of the submandibular gland. So the Wharton's duct arises from the deep part and is in close relation to the lingual nerve. Coming to the sublingual gland, it lies immediately lateral to the submandibular duct in the sublingual fossa. Below the tongue, there's a fossa, that is the sublingual fossa, where the submandibular gland lies. The overlying mucosa of the submandibular gland is called the sublingual fold that you can see in the floor of the mouth. It drains via multiple small ducts. Coming to pathology of the major salivary glands, the WHO has classified benign all the tumors that arise in the salivary glands into benign tumors, malignant tumors, non-neoplastic epithelial lesions, benign soft tissue lesions, and hematolymphoid tumors. From this classification, we can see that there are a number of varieties of malignant, benign, and other tumors that may be seen in the major salivary glands. This image shows the site of origin of different histological types of tumors in the salivary gland. From the acinar cells, you get the acinic cell carcinoma. From the intercalated ducts, you can see a multiple tumors arising. The pleomorphic adenoma, which is the most common benign tumor of the parotid of the salivary glands, that is most commonly seen in the parotid, arises from the intercalated duct portion of the salivary gland. From the striated duct portion, we can see that the Watten's tumor and the oncocytic carcinoma arise. And from the excretory duct portion, the mucoepidermoid carcinoma, salivary duct carcinoma, and adenocarcinoma are said to arise. Pleomorphic adenomas, 40 to 70% of all tumors of salivary gland are pleomorphic adenomas. They are most commonly seen in the parotid tail. The mean age of occurrence of pleomorphic adenomas is 40 years with a male predominance. The slow-growing tumors with a high rate of recurrence, surrounded by a pseudocapsule. There's a risk for malignant transformation of 1.5% within 5 years and increases to 9.5% when the tumor has been there for more than 15 years. Watten's tumor is the second most common benign tumor. It's a slow-growing tumor that is exclusively seen in the parotid. It's seen in older men who are smokers more commonly. Watten's tumors contain epithelial and lymphoid tissues, and they're also called adenolemphomas. They have a thin capsule. They have a bilateral incidence of 10% and have no malignant potential. Other benign tumors include oncocytomas, sebaceous neoplasms, or non-epithelial tumors like lipomas and hemangiomas. Coming to malignant tumors of the major salivary glands, the most common malignant tumor of the parotid is the mucoepidermoid carcinoma that is seen in patients who are 30 to 50 years of age and with an equal incidence in males and females. It is the most common malignant salivary tumor in children. It occurs commonly in the superficial lobe of the parotid. Mucoepidermoid carcinomas can be of high grade or low grade. If there is more of the epithelial component or the epidermoid component, they're called high grade, and more mucinous component makes them low grade. High grade lesions have increased lymph node mets up to 40% and distant metastasis and have shorter survival rates, therefore. Coming to adenoid cystic carcinoma, it is the most common salivary malignancy overall. 2 to 6% of parotid tumors and up to 15% of submandibular tumors are adenoid cystic carcinoma. 2/3 occur in the minor salivary glands. They have an indolent growth, but they're peculiar in that they have a perineural invasion. They have late recurrences and distant metastasis. There are various histological types of adenoid cystic carcinoma. These include tubular, cribriform, and solid. The histological type decides the prognosis of these tumors, with tubular having the best prognosis and solid having the worst prognosis. Regional lymphatic spread in these tumors is uncommon. Mixed malignant tumors are pleomorphic adenomas, which then become carcinoma ex pleomorphic adenoma, or a de novo mixed malignant tumor. They are 2 to 5% of malignant salivary gland tumors. They're seen in patients with a history of multiple recurrences following surgery and RT. In such patients, a mixed malignant tumor should be suspected. High grade with a high incidence of hematogenous metastasis. Other malignant tumors include acinic cell carcinomas, which are 3% of parotid tumors with a peak incidence in the 5th decade. These present as small indolent peripheral lesions. Patients can also have tumors such as lymphomas, the non-Hodgkin's variety being the most common, and these occur very commonly in patients with Jogman syndrome. Or malignant tumors can be metastatic tumors, that is carcinomas and melanomas, from various primaries in the scalp, temporal area, and ear. Also distant metastatic tumors, but these are very rare. arising from the lung, kidneys, and the breasts. Coming to the evaluation of tumors of the major salivary glands. So on clinical examination or from the patient's history, these are slow growing masses. Pain, rapid growth, nerve weakness, and paresthesia suggest that the tumor is probably malignant. Malignant tumors may invade the adjacent skin, muscles, and bone. 20 to 25% of malignant masses can present as clinical or occult lymph node metastasis. In the parotid gland, tumors that arise in the deep lobe invade the parapharyngeal space. They produce trismus because of pterygoid involvement and can also produce symptoms of facial palsy. Tumors of the submandibular gland may be fixed to the mandible. They may invade the mylohyoid muscle, the 12th cranial nerve, lingual nerve, and produce paralysis or paresthesias of the tongue. The sublingual gland tumors may present as submucosal or ulcerated mass in the floor of the mouth. On examination, in a parotid swelling, there is a characteristic feature that the earlobe is lifted. When the deep lobe is involved, there can be a swelling seen in the oral cavity, as can be seen here. This is the deep lobe of the parotid that can be seen from within the oral cavity. Oral cavity examination may also reveal tumors of the sublingual and minor salivary glands. Bimanual palpation of the mass will help to assess fixation of the mass to the surrounding structures. A pleomorphic adenoma are spherical when small. When large, they develop a flat, deep surface and slightly pointed superficially. They may also become lobulated. They're rubbery or hard in consistency, can be differentiated from a periauricular lymph node due to limited mobility within the tough capsule of the parotid gland. A Wathen's tumor is usually seen in the lower part of the gland at the lower border of the mandible. They're small, smooth, well-defined, distinct, soft and fluctuant tumors. There is no involvement of lymph nodes or skin in these tumors. On examination, low-grade malignant tumors may be indistinguishable from benign tumors. They may be indistinct, slightly tender, firm to hard in consistency, fixed to the underlying structures. These features suggest a malignant tumor. Other features that suggest malignancy include facial asymmetry, numbness of the tongue, cervical node involvement, mandibular swelling or tenderness. Investigations. The first investigation that needs to be performed for a mass suspected to be in the parotid or submandibular gland is the ultrasound. CT and MRI can be used for preoperative planning and staging. MRI is better than CT at predicting malignancy and more sensitive for small tumors. CT role is limited to the evaluation of cortical bone and presence of calculi. CT is also useful, however, to exclude distant metastasis. MRI will show marrow infiltration, perineural spread, and involvement of the facial nerve. T2 weighted scans will help differentiate benign from malignant lesions because benign tumors will show high signals while malignant tumors may show low to intermediate signals. MR spectroscopy can differentiate malignant from benign tumors and also differentiate Wathen's from true pleomorphic adenoma. On PET, Wathen's and oncocytomas will show uptake of technetium-99. FNA, for the evaluation of suspected mass, it's also used as an adjunct for surgical planning. The sensitivity and specificity of FNA are said to be around 80 and 90%. Ultrasound-guided FNA is performed as a standard for all salivary tumors in the UK. The challenges associated with FNA include the following. As we already saw, according to the WHO classification, there are a number of pathologies that can be seen in benign and malignant salivary gland tumors. Due to the diversity, these can be difficult to identify on an FNAC. The morphological overlap between benign and low-grade malignant tumors is another concern. So on FNA, it will be very difficult to differentiate a benign tumor from a low-grade malignant salivary gland tumor. There's a wide spectrum and morphologic heterogeneity of cellular elements within the same salivary gland tumor, which also makes diagnosing a particular histology on FNA challenging for the pathologist. There are also a certain number of rare tumor types, which is another challenge for the pathologist reporting the FNA result in a suspected salivary gland mass. So the Milan system of reporting is a standardized system used for reporting the cytopathology appearing from salivary gland. This is considered for cases where definitive diagnosis may be not possible. So the categories under the Milan system can be non-diagnostic, which means an FNA might be, a repeat FNA might be required, non-neoplastic, which only which only clinical follow-up may be sufficient, or the mass can contain ATP of unknown significance. It can be a benign mass or a salivary gland neoplasm of uncertain malignant potential, suspicious for malignancy or malignant. These classes help predict a risk of malignancy, as can be seen here, and therefore determine the further management that needs to be performed. So the salivary gland tumors, just like all other malignancies in the body, are staged according to the TNM classification by the AJCC. This here is the 8th edition, which is the latest edition of AJCC classification of tumors. According to this, the tumor is classified based on the tumor size, lymph node status, and metastatic status. The T classification is as follows. T1 is tumors less than 2 centimeters in greatest dimension without extraparenchymal extension. T2 are tumors which are more than 2 centimeters but less than equal to 4 centimeters without extraparenchymal extension. If there is extraparenchymal extension or the size of the tumor is more than 4 centimeters, they're called T3. T4 tumors show invasion of surrounding structures. Invasion of the skin, mandible, ear canal, and facial nerve are T4A. Invasion of the skull-based pterygoid plates or encasement of the carotid artery are T4B. Coming to the end staging, N1 tumors represent a single ipsilateral, which is on the same side as the gland that is inward, and the node is less than 3 centimeters. N2 nodes are either more than 3 centimeters but within 6 centimeters on the same side, or multiple nodes, none of which are more than 6 centimeters, or metastasis in both sides or contralateral nodes, again not more than 6 centimeters. When a node is larger than 6 centimeters, the stage moves on to N3. N3B is metastasis in a node with extranodal extension. As for all other tumors, many other tumors, the end stage is M1, M0 or M1. M0 is no distant metastasis and M0 is the presence of distant metastasis. Based on the T, N and M categories, a tumor is staged. So a tumor that is T1, N0 is stage 1. T2, N0 is stage 2. T3, N0 or N1 is stage 3. T4A, N0 or till N2 is stage 4A, and T4B is stage 4B, and presence of metastasis is stage 4C. Coming to the management, surgical excision is the mainstay of treatment of these tumors. For the parotid glands, a superficial parotidectomy with facial nerve dissection and preservation is the standard diagnostic procedure. So as we have discussed before, obtaining an FNA may not be sufficient in all cases. So an excisional biopsy has to be performed. So this in case of a parotid gland tumor is performed in the form of a superficial parotidectomy with facial nerve dissection and preservation. Total parotidectomy needs to be performed for tumors that involve the deep lobe of the parotid gland. For the submandibular gland, benign tumors should be excised via an extracapsular excision, and malignant tumors should be excised en bloc with the level 1B lymph nodes. This is also called a omohyoid neck dissection. Now coming to the surgical excision of the parotid gland, The principles of excision involve obtaining a cuff of normal tissues around that should be resected along with the tumor. And while resecting, the adequacy is determined by frozen sections. For benign tumors, facial nerve should be preserved. For malignant tumors, facial nerve should still be preserved by peeling the tumor off the nerve. However, when there is gross involvement, the nerve may be sacrificed with a proximal negative margin, and immediate nerve grafting should be considered whenever possible. The steps of superficial peritidectomy briefly involve the following. It's done for a superficial peritidectomy is considered therapeutic in case of a benign tumor of the superficial lobe or a small malignant tumor limited to the superficial lobe. This incision, the S-shaped incision seen here, is called the modified Blaise incision. Once the incision is made, a skin flap is raised anteriorly staying below the platysma. This is called the subplatysmal plane. Now, as I mentioned before, the facial nerve identification of the facial nerve is an important part in parotid gland surgeries. So now the main trunk of the facial nerve is exposed and identified, and all gland that is above the facial nerve, that is the superficial lobe, is dissected off the branches of the facial nerve. When the facial nerve is injured, it must be repaired immediately. Hemostasis should be secured with diathermy to enable visualization of the nerve. Extracapsular dissection of small benign tumors where the capsular integrity is maintained reduces the incidence of a Fraze syndrome. There are multiple landmarks proposed for the identification of the facial nerve, including the tracheal pointer, the posterior belly of the digastric muscle, the tympanomastoid suture, junction of the bony and cartilaginous part of the external auditory meatus. Also, the facial nerve can be identified when it exits the skull at the stylomastoid foramen near the styloid and mastoid processes. Total conservative peritidectomy involves performing a superficial peritidectomy followed by dissecting the nerve free from the deep lobe and then excision of the deep lobe plus tumor. So here the nerve is preserved and both the superficial and deep lobes are removed. Sometimes when the tumor invades the mandible, a partial mandibulectomy may be required. This may also be required to access the deep lobe of the parotid gland. Intraparotid nodes are removed along with the primary lesion. If nodes are positive, a neck dissection should be performed in the form of a modified radical neck dissection. A radical peritidectomy involves the removal of the entire parotid gland, the facial nerve, and other involved tissues such as the skin, bone, and muscle. This may be performed for malignant tumors, which are of a higher stage and involve these surrounding structures. Sometimes a mastoidectomy may need to be performed if the facial nerve is involved at the stylomastoid foramen. In these cases, postoperative RT should be delayed. Tumor recurrence is seen 2% in benign tumors which undergo extracapsular dissection and 5 to 10% in superficial peritidectomy. In malignant tumors without RT, recurrence is quite high, up to 50 to 60%. Recurrence of tumors after surgery can usually be managed by postoperative radiotherapy. The complications of peritidectomy include facial nerve palsy, which can be temporary or persistent. It's temporary in 5 to 10% of patients and persistent in 1%. Facial nerve palsy can be graded according to this classification that is seen here. It's called the House-Brackman grading. The primary goal of facial nerve rehabilitation in a patient that has facial nerve palsy after surgery is protection of the cornea from exposure. That is the most common complication that is seen. Because of facial nerve palsy, the cornea is exposed because the upper eyelid remains slightly open. So protection of the cornea from chronic exposure is the primary goal in these patients. Other symptoms or issues that need to be addressed include oral competency, nasal valve maintenance, and cosmesis. Options for facial nerve palsy include surgical options such as nerve grafting, a brow lift, gold weight implantation into the upper eyelid, lower eyelid tightening, or facial suspensory procedures. Other complications include gustatory sweating or Fraze syndrome, which is seen in 10% of patients after peritidectomy. Fraze syndrome can be prevented by maintaining a barrier between the parotid parenchyma and the skin. The management of Fraze syndrome includes antiperspirants, which usually contain aluminum chloride, or denervation by tympanic neurectomy, injection of botulinum toxin into the affected skin, which is the most effective and can be performed as an outpatient procedure. Other complications include hematoma formation, infection, deformity, unsightly, such as due to an unsightly scar or retromandibular hallowing, a sialocele, or numbness of the earlobe associated with great auricular nerve transection. Coming to the submandibular gland, the standard approach is to excise the submandibular gland through a transverse neck incision and followed by lifting a subplatysmal flap. The facial vessels which are associated with the gland are ligated, and the gland is dissected from the posterior belly of the digastric muscle. Here you can see the digastric tendon here. Below this will be the submandibular gland. The lingual hypoglossal nerves are identified and preserved. The duct, which is the Wharton's duct, is ligated and the gland is excised. In sublingual tumors, en bloc wide dissection involving the overlying mucosa and adjacent periosteum should be performed. And if there are neck nodes, lymph node dissection may be required. Immediate reconstruction is recommended in these patients. Reconstruction can be performed by flap procedures that may include a radial artery forearm flap or an anterolateral thigh flap. In sublingual tumors, which have a high incidence of malignant tumors, the threshold for adjuvant radiotherapy should be low. Elective neck dissection is maybe recommended in patients who do not have lymph nodes. So in an N0 disease, elective neck dissection may be performed. However, this is controversial. High-risk factors include high-grade tumor, advanced stage, tumors with extracapsular extension, presence of preoperative facial nerve palsy. In these patients, elective neck dissection may be recommended. Selective neck dissection, that is levels 1B, 2, 3, 4, and 5A for the parotid, and 1, 2, and 3 for the submandibular gland, should be performed whenever lymph nodes are positive. When the lymph nodes are positive, clinical or radiologically, modified neck dissection should be performed. Radiation therapy is used as an adjuvant. The indications include cases in which there is a high risk of recurrence, either high risk of local recurrence or nodal recurrence. The high risk of local recurrence may be because of certain pathologies, positive margins, perineural invasion or spread, or tumor in the deep lobe. Also, there are some relative indications. Similarly, there are nodal recurrence can also be high in high-risk pathologies, advanced tumors, or in tumors with nodal involvement with extracapsular extension. Relative indications include lymphovascular invasion and facial nerve palsy. Other indications include recurrent or recurrence after resection or deep-seated tumors in the parotid. The minimum treatment volume for the parotid is the parotid bed with the upper neck nodes. Radiotherapy may also be indicated as a palliative measure in large fungating masses or to achieve hemostasis in bleeding tumors. Techniques of radiation therapy can be conventional, three-dimensional conformational radiotherapy, intensely modulated radiation therapy, or neutron beam radiotherapy. EMRT and neutron beam radiotherapy are newer techniques that are now used, which have lesser complications than the conventional technique. Complications of radiotherapy include xerostomia, which can be avoided by sparing the contralateral salivary tissues. There can be trismus because of fibrosis of the masseter and pterygoid muscles and the temporomandibular joint involvement. There can be otitis. Patients can develop otitis media. If the ear is irradiated, there can be localized hair loss with some techniques. A rare complication that can be seen with high doses of radiation therapy is osteoradionecrosis of the mandibular bone. Newer therapies for parotid malignancies, as seen in a lot of other malignancies, is the targeted therapy. This here is a list of targeted therapies that can be used for different types of pathologies of salivary gland tumors. This slide summarizes the stage-wise treatment as per the NCCN guidelines. So the mainstay of treatment is surgery for all stages, unless when resection is not possible, in which case directly definitive RT may be tried. But in all other stages when resection is possible, surgical resection should be followed by RT if required or follow-up. The follow-up examination should include history, physical examination, imaging with a CT or MRI, 3 to 4 months after definitive treatment, and PET after 3 to 6 months after RT. Patients should have a THH every 4 to 6 months if the neck is irradiated. They should also have dental evaluation. Patients should also receive supportive care and rehabilitation for problems with hearing or speech and swallowing, nutritional evaluation and rehabilitation until the patient is stabilized, oncologic surveillance for depression, also counseling for smoking and alcohol cessation. Coming to the minor salivary glands, minor salivary glands can be seen spread across the entire upper aerodigestive tract except the gingivae and the anterior portion of the hard palate. Aberrant salivary tissue can be seen in lymph nodes, mandible, retromolar trigone. Tumors most often occur in the hard palate, nasal cavity, and paranasal sinuses. The most common type of tumor is an adenoid cystic carcinoma, which has a high rate of these minor salivary gland tumors have higher rates of aggressive malignant tumors. Local infiltration and nerve involvement are more common. Tumors are more central than peripheral and characterized by skip areas. Lymph nodes involvement is based on the site of origin of the tumor and histology. Higher rates in tumors of the hard palate and nasal sinuses. And half of high-grade tumors have lymph node involvement. On evaluation, these may present as indolent painless submucosal masses with ulceration seen seldom in these patients. Ulceration may also occur in benign tumors, rarely. Pain can also be seen due to nerve involvement or perineural invasion. Examination should include search for lymph nodes. Benign tumors less than 1 centimeter can undergo an excisional biopsy. If it's more than 1 centimeter, malignancy is suspected. A punch biopsy should be performed, followed by definitive surgery. Staging for the minor salivary gland tumors is similar to squamous cell carcinoma of the oral cavity. Coming to the treatment, if benign, the treatment is surgical, mainly surgery, which includes excision, including the en bloc excision, including the overlying mucosa and primary closure. For small tumors, an excisional biopsy can be performed and the tumor can be left to heal by secondary intention. These images show the excision of a minor salivary gland tumor of the upper lip. Here is the raw area after excision, which is closed primarily. For low and intermediate grade tumors, RT may be considered as the primary treatment for inaccessible lesions or when functional loss may be significant. For high grade tumors, surgery should be followed by RT, but at the cost of loss of function and cosmesis. Sometimes a segmental mandibulectomy, total or partial resection of the palate with reconstruction may be required for these tumors. So to summarize, salivary gland tumors in general are rare, so is there evidence for management. The main keystone of management for both benign and malignant diseases is surgery. Preoperative planning is crucial, with MRI as the preferred investigations whenever available. Adjuvant radiation is indicated for features suggesting high risk for local or nodal recurrence. There is a need for higher level of evidence for treatment of unresectable or inoperable tumors.